Hey everyone, Chris here from MedPrep2Go, and I wanted to let you know about our premium Step 1 Bundle podcast, which gets you all of Crush Step 1 and our Step 1 Question podcast combined and ad-free. You'll also get early access to new content as it becomes available. Upgrade your studying now and learn more at medprep2go.com. Hey everyone, Chris here from MedPrep2Go, and I wanted to ask you to please follow us on social. There may be links in the show notes, or you can find us at MedPrep2Go on Facebook, Instagram, LinkedIn, and now YouTube. We would greatly appreciate it as we try to spread the word about MedPrep2Go and keep medical education accessible and affordable. Hey everyone, Chris here from MedPrep2Go, and I wanted to let you know about our premium Step 2 Bundle podcast, which gets you all of the Step 2 secrets and our Step 2 Questions podcast combined and ad-free. You'll also get early access to all of our Step 2 Questions episodes before they're released public. The bundled podcast is available now, and you can save over 40% with an annual plan. Details at medprep2go.com. Hey everyone, Chris here from MedPrep2Go, and welcome to another episode of our USMLE Step 1 Questions podcast. I'll be your host for today, and in this episode, I'll be reading 3 pathology questions from our online qbank. As always, you can read these questions and more at medprep2go.com. And with that being said, let's get started with question 1, Pathology 49. A 36-year-old woman presents to her primary care physician with lethargy and poor balance for about 4 months. She is a drummer in a traveling band and states that she has had trouble performing due to lack of energy and difficulty coordinating her drum movements, as well as headaches and lightheadedness. She has a history of primary biliary cholangitis managed with ursodiol, and her mother is living with rheumatoid arthritis currently. She endorses a vegan diet and exercises regularly. She reports occasional marijuana use and denies any tobacco or alcohol use. Vital signs are within normal limits. Physical examination shows pale conjunctiva and an inflamed tongue. Neurologic examination reveals decreased limb proprioception and vibratory sensation. Laboratory studies reveal hemoglobin of 9.8 grams per deciliter, a mean corpuscular volume, MCV, of 125 cubic micrometers, and increased levels of methylmalonic acid. Based on these results, she is referred for an upper endoscopy, and histology of a biopsy from the stomach reveals diffuse atrophy of gastric body and fundus mucosa with intestinal metaplasia. Based on the current diagnosis, the patient is at highest risk for which of the following conditions? Is it A, carcinoid tumor, B, esophageal squamous cell carcinoma, C, gastric adenocarcinoma intestinal type, D, mucoepidermoid carcinoma, or E, pancreatic adenocarcinoma? And the correct answer is C, gastric adenocarcinoma intestinal type. This patient has evidence of chronic autoimmune gastritis, a personal and family history of autoimmune disease, macrocytic anemia, vegan diet, vibratory sensation impairment, and proprioceptive deficits should raise suspicion for vitamin B12 deficiency. Vitamin B12 deficiency is an important feature of chronic autoimmune gastritis because gastric parietal cells are being destroyed, releasing less intrinsic factor. Histology reveals diffuse gastric atrophy of the stomach body and fundus with intestinal metaplasia seen in autoimmune gastritis, which is a risk factor for gastric adenocarcinoma intestinal type. Answer choice A, carcinoid tumor, is incorrect. Carcinoid tumors are neuroendocrine malignant tumors that can arise anywhere, but the small intestine is the most common site. If it metastasizes from the small intestine to the liver and into systemic circulation, carcinoid syndrome and carcinoid heart disease can result. Carcinoid syndrome presents with bronchospasm, diarrhea, and skin flushing. Chronic autoimmune gastritis is not associated as a risk factor. Answer choice B, esophageal squamous cell carcinoma, is incorrect. Esophageal squamous cell carcinoma has many risk factors, including alcohol and tobacco, which is avoided in this patient, very hot tea, achalasia, esophageal web, and esophageal injury. Chronic autoimmune gastritis is not associated as a risk factor. Answer choice D, mucoepidermoid carcinoma, is incorrect. Mucoepidermoid carcinoma is a malignant tumor made of mucinous and squamous cells in the salivary gland that could involve the facial nerve if invasive. It is not related to chronic autoimmune gastritis. Answer choice E, pancreatic adenocarcinoma, is incorrect. Pancreatic adenocarcinoma is more commonly seen in the elderly population, and the major risk factors include chronic pancreatitis and smoking. Key learning point. Autoimmune gastritis is associated with autoantibodies against intrinsic factor and/or parietal cells. The destruction of parietal cells and intrinsic factor leads to vitamin B12 deficiency and pernicious anemia, which can present with proprioceptive and vibratory deficits, generalized weakness and lethargy, glossitis, and lightheadedness. Chronic autoimmune gastritis affects the body and fundus of stomach while sparing antrum, but otherwise has a diffuse pattern with intestinal metaplasia. Patients with chronic autoimmune gastritis have an increased risk of developing gastric adenocarcinoma intestinal type. Question 2, Pathology 50. A 49-year-old man presents to the cardiologist as an outpatient with a month-long history of progressively worsening shortness of breath, orthopnea, fatigue, and leg swelling. He denies any fever, nausea, vomiting, palpitations, angina, diaphoresis, or loss of consciousness over this period. Past medical history is significant for hyperlipidemia and gout. Current medications include atorvastatin and allopurinol, which are both taken consistently at appropriate doses. He drinks 25 to 30 beers per week, which has been relatively consistent for the past 30 years. He has smoked 1 pack of cigarettes daily across this time as well. Vital signs are temperature of 37.1 degrees Celsius, 98.6 degrees Fahrenheit, blood pressure of 135/82, pulse is 105 beats per minute, and respiration is 15 per minute, with oxygen saturation of 98% on room air. On physical examination, he has jugular venous distension, bilateral rales over the lower lung field on auscultation, and 2+ pitting edema to the shins bilaterally. A transthoracic echocardiogram shows an ejection fraction of 30% with left ventricular dilation and no significant valvular abnormalities. The ejection fraction is reduced from 55% measured 2 years ago. Which of the following is the most likely underlying mechanism contributing to this patient's condition? Is it A, alcohol use, B, aortic stenosis, C, chronic hypertension, D, hemochromatosis, or E, ischemia? And the correct answer is A, alcohol use. This patient has evidence of heart failure with reduced ejection fraction, along with signs of fluid overload such as lower extremity edema. Long-term excessive alcohol consumption is a leading cause of acquired dilated cardiomyopathy. Left ventricular dysfunction and alcohol-induced cardiomyopathy are related to the mean daily alcohol intake and the duration of alcohol consumption, though the pathogenesis is not fully understood. Chronic alcohol consumption may impair myocardial contractility due to the effects of ethanol and its metabolites. Answer choice B, aortic stenosis, is incorrect. While aortic stenosis can lead to heart failure, this is usually due to concentric hypertrophy secondary to increased pressure in the left ventricle. The echocardiogram findings in this patient show left ventricular dilation and reduced ejection fraction, which would more likely be seen with aortic regurgitation. Answer choice C, chronic hypertension, is incorrect. Chronic hypertension would also present with concentric hypertrophy as opposed to dilation, which is due to eccentric hypertrophy. Answer choice D, hemochromatosis, is incorrect. Hemochromatosis is an iron overload disorder that can lead to dilated cardiomyopathy. However, this condition is usually accompanied by systemic symptoms such as diabetes and skin changes. Answer choice E, ischemia, is incorrect. While ischemic heart disease can lead to dilated cardiomyopathy, this patient does not have symptoms of ischemia or a history of myocardial infarction. With an extensive history of alcohol use and associated sequelae such as gout, alcohol is a more likely cause of his symptoms. Key learning point. Chronic excessive alcohol consumption is a leading cause of dilated cardiomyopathy. Do you need a break from studying? Check out the Dr. Raj podcast, where he discusses topics such as wine with Jesse Katz, sarcoidosis with Bob Saget, saving the bees with Sydney S. Sill, and so much more. The podcast also features guest host Becca Spar, who focuses on leadership and connection, as well as Dr. Michelle Kulai and her Everyday Rooms segment. where she talks to patients to share their stories and the challenges that come with different conditions. Just search for the Dr. Raj podcast wherever you're listening now and tune in for a variety of great guests and topics. Question 3, Pathology 51. A 68-year-old man presents to the emergency department with a 2-day history of fatigue, rash, and abdominal pain. The rash had started on his feet and palms and spread to his trunk, with each lesion being roughly 1 centimeter in size. Past medical history is significant for an allogenic liver transplant 3 weeks prior, hyperlipidemia, and obesity. Medications include tacrolimus, mycophenolate, and prednisone, which have all been taken consistently at appropriate doses. He consistently drank about 30 beers every week for the past 45 years, quitting 2 years ago. He does not have a smoking or recreational drug history. Vital signs are temperature 37.1 degrees Celsius, or 98.6 degrees Fahrenheit, blood pressure of 116/78, pulse 106 beats per minute, respirations 19 per minute, and 97% oxygen saturation. On physical examination, he has a maculopapular rash on his chest and arms, as well as diffuse abdominal tenderness with guarding. CBC shows decreased levels of platelets, erythrocytes, and leukocytes. AST, ALT, and GGT are within normal limits. Flow cytometry shows low levels of CD3+ and CD19+ cells. Abdominal ultrasound does not show obvious abnormalities. Which of the following is the most likely mechanism for this patient's symptoms? Is it A, hemolysis of red blood cells? B, infection due to immune suppression? C, serositis due to systemic lupus erythematosus, SLE? D, type 2 hypersensitivity reaction? Or E, type 4 hypersensitivity reaction? And the correct answer is E, type 4 hypersensitivity reaction. This patient is exhibiting graft versus host disease, a type 4 hypersensitivity reaction occurring after hematopoietic stem cell or liver transplant. This reaction is due to donor T cells attacking host tissue. Since the T cells are from the donor liver, liver function tests are unaffected. Answer choice A, hemolysis of red blood cells, is incorrect. While hemolytic anemia may occur after transplantation, it would primarily cause symptoms of anemia such as decreased hemoglobin and hematocrit and elevated bilirubin levels rather than a rash and abdominal pain. Answer choice B, infection due to immune suppression, is incorrect. This patient is immune suppressed because of the medications he is taking, but does not have signs of infection such as localizing symptoms, fever, elevated white blood cell count, or abnormal findings on ultrasonography. Answer choice C, serositis due to systemic lupus erythematosus, SLE, is incorrect. SLE can cause a rash, particularly a butterfly rash on the face, but this typically does not present on the chest or hands. This patient does not have findings consistent with serositis or lab results that support a diagnosis of SLE. Answer choice D, type 2 hypersensitivity reaction, is incorrect. A type 2 hypersensitivity reaction would lead to acute transplant rejection of the donor graft. In this case, the liver is unaffected. Key learning point. Graft versus host disease, a type 4 hypersensitivity reaction, can occur after transplant, classically of the liver, or hematopoietic stem cells due to the presence of donor T cells in the transplanted tissues. These T cells do not attack the transplanted organ. And that will conclude this episode of our USMLE Step 1 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrep2Go on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. You can learn more and read other Step 1 questions at medprep2go.com. Happy studying!